All right, and I think we usually we start out just kind of going around telling your experience, like as far as
who you are, what you do, why you are interested in this talk, or what's going on.
Okay.
So, where do you want to start?
yeah, we'll start right there.
I can start.
Okay.
I'm Leah. I work with elementary age special ed kids in Clarence, and are potentially going through premenopause. I don't know, somewhere in there, some weird symptoms, and I was just interested in women's health, and you're presenting on that, so decided to come to this.
Great. Welcome.
I'm Christine. I also work with kids in the area as crisis support or behavior support in an elementary school. I had been on the other side of menopause for about 12 years. I started it very early. I had my last child at 31 and nothing ever went back to the same, and I was gaslit for about 10 years.
What's that mean?
It was not you.
that means like you
So
were,
what
like,
does that
shut
mean?
down,
Just like
suck it up
no,
all the
you're
time?
not.
Oh.
You're too young to be going through.
Okay.
It's too early. Oh, okay, because my mother was completely done at 38, and I was in my middle of my 30s, and I never felt hurt. I never felt whatever, and so there was times where I thought I was having a mental health crisis and like ready to commit myself, and because of my emotion, like I work in behavior support. I'm a pretty level-headed person, but in my 30s I was absolutely losing my mind. And then at 42, that was the last time I ever had anything, like any kind of shed or anything. I'm here because, as people often remind me, you still have hormones and you still may need support. And it's a different kind of season in my life, so I'm feeling like maybe I do need some support. And also my daughter, who is 31, about to be 32, is starting to have a lot of the same symptoms and is starting to be shut down with her medical care the way I was. And so I'm like, don't listen to him. I'm going to go see this doctor. And if I like her, you're going to go see her because she's going to listen to you.
Okay.
So that's it.
Ready to help. I got answers for you.
Yes.
Yeah.
Hi, I'm Darlene. I'm a social worker, so we got,
awesome.
but I recently forced retirement because my job ended. But
Oh man.
I'm
In a good way?
I'm okay. I was only working part-time anyways, so,
Okay.
so I'm okay with it. I'm all good. I've just heard great things. But I'm nearing 60, so I'm through all this, I feel like. But every day I wake up tired, and when I'm making my bed, can't wait to go back. So that explains it. Luckily I can rest during the day. I also eat vegetarian, so I don't know if I'm totally lacking something, and that's why I'm chronically tired. But other than that, I'm good.
Okay.
Yeah, thanks.
Okay.
I'm Jessica. I'm a visual merchandiser for Target. I work.
What does that mean?
Oh, it's a lot of things. To try and sum it up simply though, I take care of like all the displays, the mannequins, the big signing, like the stuff that's hanging from the ceiling or like the giant fabric signs. But there's a lot of other stuff that goes along with that. Like just rearranging the departments. I'm the one that does all the designer sets when they bring in like this, like the Kate Spade collaboration and stuff like that. I'm in charge of all that stuff.
You must be very good. I love Target.
I used to work at the one by the Galleria Mall, but I transferred. I'm now at the one in Victor because I moved back to Byron. So it's a little bit closer of a drive. I love my job, but I'm about to turn 40, and for a while I thought I was like, I'm over exaggerating. I thought I was like dying or there was something wrong with me because I had all these weird things going on. And then I researched about perimenopause. And this is my aunt. And menopause does tend to come a little earlier in our family. So Like, I am just here to learn everything to try and manage all of the oh so wonderful things I'm going through.
Okay.
And hormone therapy. I would like to hear about that.
Hi, I'm Aunt Cindy. When I did work, I was a nurse. I haven't worked in a long time. I started hormone therapy 6 months ago. Best thing I ever did right now. And I'm here to support her because I've been after her saying, your menopause starts before you're 40, Jess. So I'm here to support her and to learn more to make sure I'm on the right track too.
Okay, good.
I'm Jerry. I'm here because I don't want to break my streak of missing a single session.
She's got groupies.
I can't. I learn something every single time. I have been a patient of Dr. Coggins for probably 9 months or so now, and I feel better than I've felt in my whole life. I feel healthier. I feel younger. It's so many things that I didn't think were fixable are fixable. And I had hysterectomy very young, and then I took estrogen and for a long time, just like, and then got some misinformation and then went off for a while and then started therapy that was very good, but what I didn't realize was there was great out there. So I feel like there's different levels, and I love the way that Dr. Coggins does it because I feel like she is like up level. She looks at everything and she takes the time, and I do seriously learn. And I also have I spoke before as a financial planner, and I do have a lot of connection with a lot of women of all ages, and I love to, like Sarah, I feel like we're connectors. I love to pass on good information. You know, when you find somebody that's doing a great job, you just like to, get it to anybody that might need it. So that's why I'm here. Well, I'm here because this is my place, and because I found Dr. Coggins, thank God, and it's been more than a year now, and like, it's such a game changer, like you said. Like getting the prescription is a start, and it's good if people are on board. But getting it managed properly that's been what it's all about. And unfortunately, there's not many people who are out there doing that. So that's why I tell everybody, and everyone's been seeing her. So I'm very, very thankful to have
My
her here.
OBGYN also recently retired, so I am looking for a new one.
Okay, so
And then wait, you just have one more.
okay, go ahead.
I'm Lindsay. I'm only 26, so I have some time before menopause, but I'm a Reiki practitioner. I'm a social worker as well, so I'm very passionate about wellness in general, especially holistic and women's health, because I feel like we are not taught what we should be taught. So any and all information that I can get and even be prepared for the future, I'm all for that. So.
Okay, all right. I'm grateful you're all here. I'm so grateful to Sarah and Jerry. This has been so helpful, so validating, right? Validating, because I don't have a lot of support in the medical community for what I'm doing, right? So, and I'll tell you a little bit about myself. So when I first graduated from residency, every woman went on hormone replacement, right? Everybody. So if you went through menopause, you went on Prempro, and we were doing great things with it. We were helpful. And then in 2002, the WHI study came out. Is this thing? Oh, I thought it was like seeing me in the background, having this weird optical illusion of wait, is that me? Okay. And the WHI study came out in 2002, which basically said that hormone replacement caused breast cancer, heart attack, stroke, and blood clots. And even those of us, in the know at the time, semi-intelligent people were kind of like, oh, wait a minute. That's not exactly what this is saying. This is not exactly, this was a statistical trend. It wasn't actually statistically significant. And then they stopped the study early. And what the study actually showed was a decreased risk of breast cancer in the people who got estrogen only. That was never advertised, right? That never made the news. That should have been the headline. Mm-hmm. That should have been the headline. Decreased risk of breast cancer with estrogen. So the estrogen was conjugated equine estrogen. It comes from pregnant horse mare urine. There's at least 10 estrogens, only 4 of which were human, and even with that, it had a decreased risk of breast cancer. Add to it a progesterone. So there's no plant that makes human hormones, okay? There's no plant. Soy is not human hormone. That's it. It's not. So they take this plant-based molecule, take it to the lab, turn it into bioidentical, chemically, biologically identical to human hormone, and this will act the same in my body as yours, and we have the right receptors for it. It's the right hormone. If you tweak that a little bit, right? Now we got a new drug. Now we can make some money. Now we have this new name. We can have this new fancy dancy, and it's got this, added benefit that it lasts longer in your system, or you can get a shot of it and it lasts longer. But the fact of the matter is that it doesn't act the same as the bioidentical. So what turns out to be true is that it is actually the synthetic progestins, especially in combination with synthetic estrogens, that lead to an increased risk of blood clotting, heart attack, stroke. So we have spent 20 years not teaching doctors about hormones because all hormones are bad happened after that. The number of prescriptions written for hormone replacement dropped by 80% in 1 year after that study came out. And it was a train that could not be stopped. It could not be stopped. And so we have not been training any doctors on hormone replacement. It's not that they don't want to learn or they are unwilling, but there's something called confirmation bias. What you were taught first has to be true. And many doctors have that. There's no way that those studies that I learned and took exams on could possibly be wrong no matter what the data shows, whatever the new studies show. And you do have to be somewhat rigid to be a doctor, right? There's a lot to go through to get there. You have to be on a path, right? But being able to be like, hey, this new study came out and actually what I thought all along isn't so, not everybody is flexible enough for that, so that's how that goes. So I do want to start out a little bit with very basic hormone discussion of the human body. Some of you, nurse, this is probably going to be pretty simple, a good review. But I think it's important, just so you know where I'm coming from, and it's going to answer questions that you may have about your body or someone that you know, and so we'll just start pretty basic. So if we think about the normal menstrual cycle, day 1 is the first day of bleeding, day 14 is ovulation, and you know what I need? I need like an easel.
I know. I
You know what? I have an easel at home. I don't know why I never thought to bring it.
And day 28 is the same as day 1. So in the first part of the cycle, the lining layer is thick, and then we start to bleed down, and then it starts to get thick again. This, I don't know. I don't know what it would rest on though. Let's see. We'll see.
We can tape it.
Tape it?
Tape it to the wall.
Tape it, yeah, like here. This would be good.
There you go.
Improvise. See, we can improvise. We can work together. Yeah, because otherwise I'm not a good artist to begin with, and then we're gonna end up with something that everybody's gonna be like, okay, I think what she was saying. I'm not really sure what she was saying. Make sure you can see me. Can you guys see that? Okay. So then we ovulate. So this first part of the cycle, this building up the lining layer, is related to estradiol. Then we ovulate, we make a cyst. Ovaries make cysts for a living, that's their job. They make cysts every month, the cyst ruptures, and that's ovulation. And the cyst that's left behind produces progesterone. Progesterone stabilizes your lining layer. It no longer gets thicker, it just gets more dense. And then we bleed again. So in a situation where we're not ovulating, the body sees this as an excess of estrogen, and the lining layer gets thicker and thicker. When you do bleed, you bleed irregular and you bleed heavy. So who's not ovulating? Well, perimenopause. They're going to intermittently be ovulating. PCOS, polycystic ovarian syndrome, and I'll talk about that in a second. The increased estradiol also can happen with obesity because we turn any hormone we can in our body with the aromatase enzyme in our fat cells into estradiol, into estrogens. So people who are obese have thicker lining layers, bleed heavier. When we talk about what's happening, so the body is driving to make a baby, make a baby, make a baby. Even in menopause, the brain is still saying, find an egg, let's have a baby. So follicle stimulating hormone is the hormone that it's a feedback mechanism, right? So if the estradiol is low, the FSH goes up and says, find an egg, make more estrogen, make more estrogen. So when we hit menopause, this FSH goes really high. But let's talk about perimenopause. Intermittently not finding an egg, so this FSH starts going up. When it finds an egg, all of a sudden the estradiol skyrockets. So estrogen, estradiol, is the bitchy hormone, right? So this is going all over the place, up and down, up and down. You are not like maybe thinking you're crazy. You actually are freaking crazy, okay? It's not like a maybe. You actually were crazy. There's no question in my mind. So you were tearful, you were bitchy, you were road rage. All of this is estradiol. This is estradiol. Progesterone is the balancing hormone. So let's talk about PCOS a little bit. A lot of people know people who have PCOS or symptoms of PCOS, and this is kind of important. This is something that needs to be treated as a teenager in order to actually help people long term. So this is called the 2-cell theory of ovulation. So that's an ovary. Obviously that's an ovary. So every month we're making this cyst, and it's initially producing estradiol, and then we ovulate, and then it's producing progesterone. And like I said, we're driving towards ovulation, driving to make a baby. So the precursors to estradiol in the steroidogenesis pathway really start out as cholesterol. So when people start going through perimenopause and we're losing our estrogen and getting this visceral fat in the abdomen, and all of our lipid profile starts getting bad, we start getting diabetes and all that stuff. So when that is happening, they put people on lipid lowering agents, and now we further worsen our symptoms because we further blockade hormone steroidogenesis. So don't get me started on statins. So let me just say this. There are no primary data in women that it prevents the first heart attack. Say that again. Statins do not prevent the first heart attack in women. There's no data to show that. No data. In men, it prevents the first heart attack by 3%. 3% drop. Decreased risk of the first heart attack. So, I mean, they are big money, and the numbers look great, but it doesn't really prevent the first heart attack. And I'll tell you why in a minute. Okay, so we take cholesterol molecule, and then the cholesterol molecule becomes an androgen. So androgens are precursors to estrogens. So in PCOS, and even in menopause, it kind of looks like a little bit of increased androgen as the estrogen starts going down. But we don't ovulate because we have PCOS or something, perimenopause. So we make these cysts that don't actually ever rupture. So that's polycystic ovarian syndrome. But we keep making more and more estrogen, make a baby. But before the estrogen, we increase the androgen. So now you have someone with really high androgen and really high estrogen. So they have a really high voice, massively obese, full beard, right? I don't know if you've met these ladies, losing their hair, and just like, you see them in the grocery store, you see them at Walmart. I look at some of those women like, honey, I could help you. Oh my God, I just feel so sorry for them, right? Because they're losing their hair, they've got a full beard, and they're sweet as could be, sweet estradiol, and high voice. So, what happens with menopause then? So as we're periodically spiking this estradiol, we may be bleeding weirdly. Normal menopause looks like later and later periods further and further apart eventually. So we start out with our cycles, whatever they are, every 28 days, every 35 days, whatever your cycles are, all through our 20s and into our 30s. And somewhere in the 40s, we start having cycles that come closer together. This is normal. People get very nervous about this. Like, we have a very rigid idea of what the bleeding should look like. How much, what color, how many pads, when it comes, how I feel when it comes. Very rigid idea. If that suddenly changes, like, this is a cause for concern. But it's not really. So going down to 21-day cycles, pretty common. And then eventually later and later periods that are further and further apart and eventually stop. So you need a full year of no menses and a high FSH level to tell me that you are truly in menopause. And at that point, we could consider adding estrogen. If I add estrogen to someone who's in the perimenopause, their FSH level is high, and periodically they're going to ovulate, they're going to stimulate that ovary, and the estradiol is going to skyrocket. And I have lost a couple patients they've had a hysterectomy. I thought they were in menopause. It seems so long ago. Clearly they must be in menopause. I've given them some estrogen. Maybe they're better. Maybe we give a little more. And then the next thing you know, they're in the chair crying like, I can't even watch all my commercials. I can't live like this. Okay, so I've got a couple who quit me with that. But like, definitely we can fix it. If it's not working right, we can fix it. We can change it. I am a work in progress. This is a work in progress. So we'll figure it out. So at about age 40 is when the testosterone level starts going down. So we do have androgens in our system. We actually, our human testosterone level, when we're in our 20s and 30s, is actually higher than our estradiol level, our blood level. Not as high as a man, but it is higher actually than our estrogen level. So that's kind of shocking for us, but around age 40 is when that level really drops. The ovaries are starting to fail, that level really drops, and then this is very common time where people are, maybe the marriage is a little bit on the rocks because she's like, well, you know what, the kids have hockey and the play's tomorrow, and your mother's coming to dinner on Friday, and I didn't take the roast out of the freezer yet, and now you want to have sex? Like, are you freaking kidding me? No. Okay, I don't have time for that. That's really our testosterone dropping. And a lot of marriages, kind of end up in the rocks during this time. She goes to her doctor and he says, you need an antidepressant. So you're given an antidepressant, which completely inhibits orgasm and sex drive. So it blocks it. So people who have psychiatric diagnosis, who are on a fair amount of psychiatric medications, or even some SSRIs particularly, we might need a higher testosterone level, treatment level, in order to overcome the blockage from the antidepressants. And I'm not telling anybody to go off your antidepressant. If you are on a medicine that makes you well and you feel normal, then by all means you will stay on that and we will work around it. If you decide with your other doctor that you're going to come off your psych meds, that should be a gradual thing and a joint decision with your healthcare providers. I'm not trying to control anybody. So as the ovaries are failing as we age, actually all the organs are failing. So the thyroid. I have so many patients who are like, you know what, I'm tired, I am fatigued, I have dry skin, my hair has fallen out, it's dry, it's brittle, and I'm cold all the time. I'm cold all the time. I have this temperature dysregulation, which they told me was perimenopause. Well, yeah, some of the estradiol, the hot flashes, night sweats, is a dysregulation of temperature related to perimenopause and the hormonal changes. But some of it is really just the thyroid. And guess what? They're normal. Your blood levels are normal. So if you take your average, endocrinologist, he's going to look at your thyroid and be like, okay, this is normal, and you are normal, except you're here, and you're like crumbling to the ground, but you're normal, and there's nothing we can do about that. We're not going to treat that. So I kind of disagree. If I see a TSH level above 2, which is well within the normal range, I'm like, that brain is trying too hard to stimulate the thyroid. The thyroid is hypofunctioning. So I think, like for you, I feel like I'm sure that
with the dry skin and thinning hair.
It helped me so much.
go ahead, tell
Oh
me
my
your story.
God. I have been freezing, right? I would say to the doctor, I get so cold, like it's painful. It could take just driving home like 2 hours to warm up from being in the car. After taking this, like I am temperate all the time. I have barely worn a coat some days. I'm around like short sleeves when I'm doing hair now. I can't wear a sweater because I'm comfortable, and no one would ever listen to me. And it's like,
Well,
plus,
that's
I mean, it
what
does
I
give more
like.
energy as well. But like, yeah, the dry skin and the
Right.
like, it's amazing.
Mhm.
But that was all completely like.
And
no one-
was your blood,
disregard.
because my thyroid is normal.
No
because
doubt.
I had, well, on the range of
Yeah.
normal.
Yeah, no doubt, no doubt.
Yeah, it was the
But
lowest
maybe
and the normal.
So I look at blood levels, and how the patient feels. Like, how are you feeling? What are your symptoms now? What do we want to treat? How are we treating that? What does the blood level tell us? Do we have room to adjust based on your symptoms, right? So even people whose TSH, so thyroid, not follicle stimulating hormone, is suppressed from adequate replacement, if you are still having fatigue and you're on a very low dose, then we have room to go up as long as the thyroid actual hormone level is not above normal. So I've had a couple people, coming to me like, my doctor said that you're giving me hyperthyroidism. Okay, well, are you, is your blood pressure up? Are you unable to sleep? Are you having palpitations? Are you feeling jittery all the time? Are you like, what? No, none of that. I'm still fatigued. Okay, I think we got room to go up. Okay, we got room to go up. So we're gonna go ahead and do that. So I don't want to fight with anybody's doctor. I don't want to get reported to the medical board. But you know what? I got a ton of research to support what I'm doing. I don't want hassle. I will defend what I'm doing, but I don't want to fight with anybody's doctor. So
Probably men.
yeah, pardon me.
They're probably men.
Manny's the man who's doing that. But you know what? There's a lot of women OBGYNs who are, just suck it up, buttercup. You're going through menopause. It's nature's cruel joke.
That was the exact words. It's nature's cruel joke. Get used to it. That's what they told me.
Yeah. So, so some of the things that I work on replacing then would be testosterone. So I had someone say to me, this just isn't fair. They have so many medicines for men for erectile dysfunction, like all those different drugs. It's just not fair. They've got nothing for women. Yeah, that is kind of true. The thing is, though, they're not actually helping the men with these Viagra. They're giving them an erection, but they're not doing anything for their medical health, right? So they really don't have anything either that's beneficial. So really what is beneficial is testosterone. So testosterone will be converted in men, to a smaller extent in women, to estradiol. So now we come to men have estradiol too. So estradiol is actually the thing that affects the liver, that affects the lipid profile. So when we start decreasing our estradiol as we're going through the perimenopause, this is when, again, we start, I got this abdominal fat I can't get rid of now. I got this pooch. Everybody, we're all gonna get it. We're all gonna have a pooch. Because this is this visceral fat that we start building as the estradiol level goes down. Then the lipid profile starts deteriorating, and now we start making cardiac risk. So LDL is the bad cholesterol. When we're younger and we have a lot of estradiol around, our LDL is on the lower end, and our HDL, the good cholesterol, is on the higher end. Now as we go through menopause, this flips and the LDL starts going up. So what is LDL? Well, it's these smaller particles, particularly apolipoprotein B is one of the particles, and this is what causes plaque. It goes to the vessel wall, lands in the vessel wall, and forms plaque. When plaque is big enough, it ruptures, and platelets go right to the area, and this is a heart attack. So it's a plaque rupture with a platelet. The first thing that goes there is platelets in the clotting profile. If you know or don't know, but I think our nurse might know. Yep, right. So it's apolipoprotein B that goes to the vessel wall. If you lower the lipids in the blood with a lipid lowering agent, like whatever they are, I don't even use them. So with a statin, you actually are not taking it away from the vessel wall. So what's there is there, forming plaque, building up plaque, even if the blood level is low. The only thing in the world that changes pulls B away from the vessel wall is apolipoprotein A. It bonds with B, turns hard plaque into soft plaque, and pulls it away from the vessel wall. There's only one thing in the entire world that increases ApoA, it's estradiol. That's it. There's nothing else. Lower your heart attack risk by 50%. 50%. Not 3, 50%. So apolipoprotein A is what is actually going to improve your lipid profile. And maybe the numbers are not, like spectacular like they were when you were 20, or you have a, health condition, a familial thing, but it is going to help prevent plaque buildup. So, but what's important about this whole thing is that when they said that hormones were bad, they said that estrogen caused blood clots. We go back to the WHI study. So what happened with those women was that more than half of the women, and it was a good study, there were over 10,000 women, more than half of those women were over age 63, so more than 10 years from menopause. They, 50% of them were smokers, obese, or already had hypertension. So then they gave them synthetic hormones, and they had immediate plaque rupture. They had heart attacks, right? So that was the synthetic hormones. So it's taken them a long time to come up with that it is the synthetic hormones that is causing it. If you think about a birth control pill is thought to increase your risk of blood clotting, right? If you're a smoker, age 35, we gotta get you off your birth control pill because you're at increased risk of blood clotting. So those are synthetic. So it's ethinyl estradiol, which is a synthetic estrogen, and synthetic progestin of multiple generations. Progestogen, multiple generations of change in the progesterone molecule. This year they're coming out with a new birth control pill that is not ethinyl estradiol, but estradiol, bioidentical. 50% drop in the blood clot DVT risk. 50% drop in comparison to the regular pill. So it has been the synthetic hormones that give all hormones the bad rap. Give all hormones the bad rap. Can you teach that to some old school doctor who's been doing it for, not easily. No, you cannot. Recently, the FDA took away the black box warning, basically saying that, so I think the warning was that if you've ever had breast cancer and you ever touch estrogen again, it will kill you. So that was what they took away. So let's talk about breast cancer. What happens with breast cancer? Did those women actually have an increased risk of breast cancer, and why did those women on the estrogen alone not? So if you think about breast cancer, whether it's a genetic or whatever, you have mitosis. So we have cell division. It happens all through our body, right? Cells are dividing all the time. Eventually there's a DNA break. The DNA break begins a cell line that is abnormal, and in the right setting becomes the cancerous pathway that eventually becomes a cancer. So if you can decrease the mitotic rate in the breast, you will decrease the breast cancer risk. So bioidentical progesterone decreases the mitotic rate in the breast. Testosterone decreases cell apoptosis, which is cell death. So these two things alone decrease the breast cancer risk. So in that study, the women on the estrogen alone had a relative risk of 1 for having breast cancer. And then after, I think it was maybe 2 years, it went down to 0.8. And by the time they were 5 years out, they had a 0.6 risk of breast cancer. That was the real finding. That was the real finding. So estrogen does not cause breast cancer. Guess what, people? Estrogen doesn't cause breast cancer. We all have it.
Right.
Every one of us would have breast cancer if estrogen caused breast cancer. It does not. So then they told people after the WHI study, well, you know what? Even though the hormones do help the cardiac profile, so if you didn't die in that first year when you first started the hormones in that WHI study, if you didn't have the plaque rupture, after 1 year, then cardiac risk started to improve, even with the synthetic hormones, even with it. So they couldn't explain that, but they have told people for 20 years, you can't be given the estrogen to protect people's cardiac. You could give it for osteoporosis or for symptoms. Lowest dose possible, shortest amount of time. Topical if you can, just a topical, because we know that oral, like the birth control pill, causes blood clots, and they've got the studies to show that it increases different clotting factors. Again, we're in this synthetic progestin, synthetic estrogens, So yes, those do. So then they told women, well, what you need to do, you can take it topically. You can do vaginal estrogen. I mean, if you really need to feel okay here, you can take some vaginal estrogen, if you really need to. Or you could do a patch. Oh, you're allergic to the patch? Oh shit, go back to the vaginal. Messy. Who knows what stuff, right? So, turns out that the topical, first of all, it's very hard to get a blood level on the vaginal. I mean, I've tried. So if someone really does have a risk of blood clotting, like a familial, some thrombophilia, abnormal blood clotting, I am not going to get sued, okay? They are at risk for another clot, right? You're at risk for another clot. You have a blood clotting disorder, whether or not you're on estrogen. But if you get a clot and you're on estrogen, someone's going to sue me, right? So you are at risk for a clot, so you can have topical. So, just try to suck it up for a year, and if we are unable to get a blood level or you're unable to tolerate it, with the understanding that you are at increased risk for a clot, I will switch you to oral. So the oral doesn't actually cause an increased risk of blood clotting, bioidentical. It does not. But those ladies, I'm trying to get a blood level, I can barely bounce up that estrogen at all with vaginal. Topical, the patch, yes, we can get an adequate blood level, and yes, that will be enough to protect your bones. So osteoporosis. Let's talk about that for a minute. Osteoporosis, if you break a hip from osteoporosis, your mortality is 80% within 3 years. So that's a staggering statistic. When we took women off estrogens, off Prempro, off all hormones, we have a sudden, dramatic increase in bone loss and fracture. And so they came out with the bisphosphonates and the alternative treatments, like raloxifene, and that there's this one that's an IV that you get twice a year or something like that, and Prolivia or whatever it is, right? So I don't use these medicines. I do not use these. So my dear friend, my guru, who really started me on this path, she's a family medicine in Colorado, and she kind of started her path by treating osteoporosis, and she's family medicine and becoming an expert in it, and eventually came to the hormone replacement pathway and led me on my way. She had a beloved, dear patient who suffered the terrible consequence of a spontaneous femur fracture from these medicines. So when you talk about spontaneous femur fracture is the risk, I mean, she had a good cry with me. I cried right with her. She was so devastated for this poor lady. So, yeah, I don't support people who to take that, but they had to do something. So this is a huge moneymaker.
That's a thing where you just walking and all of a sudden you're...
So it is building bone. It's adding calcium to the bone. It's increasing the density of the bone. However, it is not increasing the strength of the bone. It's actually causing fragility. So the bone density looks better, but it's not normal bone density. It's not normal. So you're at risk for this devastating spontaneous femur fracture. So this is a big money maker. This is big money right now. Those studies were done long before I ever finished my residency. The studies were done to show that estrogen prevented osteoporosis, reversed it, treated it, even in relatively low doses, and the synthetic estrogens also do that. They cause the bone to lay down normally. So normally, if you go off your hormones, though, it very quickly over the next couple of years goes right down. Your osteoporosis comes back. So if you take a patch is enough estrogen to protect the bones. It is enough if you have an adequate blood level. It is not enough to protect the heart, though. It doesn't go to the liver. So you need to take, first pass effect, you take something by mouth, it gets absorbed through the stomach, it goes to the liver directly and is metabolized. It's the metabolites that are active. You need oral estrogen in order to improve the lipid profile. It has to be oral because the topical does almost nothing for your lipid profile, almost nothing. You need the first pass effect. So it has to be oral. So this is, so community-wide, people are like, yeah, we can give you the patch. Mm-hmm. Okay, well, that's fine for the bones. It does do something for the bones. But if you don't have a uterus, they're being told you don't need progesterone. Because what progesterone does is stabilize your lining there. So if you're putting someone on hormone replacement, they have a uterus. If you just give estrogen, you're going to cause this, which eventually, if untreated, or like with PCOS, if you're never ovulating and you have this really thick lining there, can lead to a precancer or even a cancer of the uterus. So you cannot give estradiol or estrogen alone without progesterone in someone who still has a uterus. Once the uterus is out, traditional medicine would say, well, that's it, you don't need progesterone. You know, we have progesterone receptors in every organ system in our body. If you take progesterone orally, bioidentical progesterone, the first pass effect leads to, goes to the central nervous system, affects the GABA receptors in the brain, and the main side effect is improved sleep quality and decreased anxiety. Let me say that again. Improved sleep quality, decreased anxiety. So how many people are just given the patch? So I have this lovely, disturbed lady that I just recently saw. She's on about 15 psych meds. 15. She had a hysterectomy at like 38. They took everything out and gave her the patch. You don't need any progesterone. And they literally have in the note, because I found the notes from 2017, they literally have in the note, patient states estrogen doesn't agree with her. She is completely a bitch on it. I was like, I left with her in the room. I'm like, you know, I just said that, right? And here's your quote. Literally. So I can help you. I can help you. I can help you. So 4 people are going through perimenopause. I am not giving you any estradiol. I would give you progesterone, bioidentical progesterone. So this will help hot flashes. This also helps bone density and prevents bone loss. This is prevents breast cancer and might be enough. Like if someone's overweight, they are making a fair amount of estrogen in their fat cells. And if I start adding estrogen to you, even though it looks like, well, your estradiol level is very low, we can add more, they've got other estrogens. So some women I'm doing fractional estrogens on to look at what's our total estrogen. And if that is elevated, then we know we can't get that estradiol up. So the other estrogen, so the menopausal estrogen is not cardioprotective. It's not. So somehow we have to shift that balance. So I am a firm believer in the GLP-1 injections. We gotta lose some weight. We just gotta lose some weight. You gotta start taking this down so that the total body fat has to come down so that we can decrease the total body of the not bad estrogen, but the not helpful estrogen, the one that makes you a little crazy and isn't really doing anything for you. As far as it's low estradiol, so it's preventing the estradiol. So, you know, I am a work in progress. I can only be on 1 milligram of oral estradiol. As soon as I start bumping that up, I'm just like, you know, why am I crying over my ex-husband? Fuck, I got over him like 10 years ago. What's going on? I'm like, oh wait, what's my estrogen? You know, I think I'll take an extra progesterone today. Oh, I'm okay. Yeah, I'm okay. So, yeah. For me, that mood change is always like ruminating about old stuff. Then I know something's wrong. I start ruminating about old stuff. I'm well over him. Okay, all over him. But so then I know my estrogen's too high. So, but I'm working on losing weight. I'm working on it. I'm on Wegovy and very happy. And you know, even my guru now. I think a lot of people went on it who didn't need it, and so now they're coming off it. And now, you know, so there's a whole thing out there. There is 3 cases in the world of a weird macular degeneration. It's called wet macular degeneration. Whether or not that's actually caused by that, I don't know, but that scared the shit out of people. So 3 cases worldwide. There are literally millions of people on this, okay? So I think it's just, I don't believe that. I just don't believe that. It's too random, just too, yeah, I don't think so. So can you come off the GLP-1s after a while? So what does it do for you? So I would say, let's see, 25 years ago probably, they were doing just a ton of gastric bypass surgery, right? So, and they've taken out people's stomachs, and people would have no hunger. All of a sudden, for the first time in their lives, no hunger for a year or more. And talking to the GI specialist was, well, there's a hormone in the stomach that actually they removed that part of the stomach, and it's a hunger hormone, and then that's gone, and so, but eventually it kind of comes back after about a year or so. So then people start gaining weight again. So back then I was like, why don't we make an anti to that hormone or block that receptor? What are we doing? Why do we do that? I could have been a billionaire. Think about that.
Yeah,
Think about that.
yeah.
You could have been a billionaire.
You don't have to worry about your retirement.
I wouldn't have to worry about my retirement, man. I'd just be like living the dream. So, yeah, so now they came up with it, right? So these actually work, on the hunger mechanism and take away a lot of the, what people call food noise or background noise of, cravings, that kind of stuff. And for me, it has changed my life. I wish it was there 20 years ago. As I was starting to go through the change and the weight gain, and I used to be able to lose weight like a mad woman, right? Because I'm gonna dance, come on. I'm just gonna eat pineapple for a couple days, and woo! I can't, nothing. You can eat pineapple only for a week, and I don't lose any weight. So this, menopause will hit you hard. So I wish it was around. I wish it was then. So I strongly believe in that. And do you come off? That's the question. And why would you? It's like insulin. Why would you come off? Why would you come off if you need it? I don't understand why you would come off. So it's a lifelong thing. It's, I am a lifelong work in progress, and that's it. So I don't see a reason that I would ever come off my hormones. So do I need to come off my hormones? Let me ask this guy. Let me ask my guru up here. So at what age would you stop women from going on hormone replacement? Would you make them stop? Would you make them stop? He's like, wait, you gonna pin me down on this? I said, yeah, I really am. When would you make them stop? Because I've been taught lowest dose possible, shortest amount of time. Those are synthetics. He said, well, okay, all right, 110. I said, oh, 110. Oh, wow. Okay, so what's the oldest you would ever start someone?
109.
110. Yeah, 110. Good. Right. So can you go on? So this was the worrisome part about the WHI study. So these 63-year-old women and older, then given hormones, had the plaque rupture and the increased clots. And if you give someone synthetic hormones, guess what? It didn't decrease Alzheimer's risk, because a lot of that is vascular and plaque. So it actually worsened vascular risk. Didn't help macular degeneration. But you know what does? Estradiol. Prevents and reverses macular degeneration. Yes.
My mom has it.
Yep.
Estradiol. It freaks me out because I don't want it.
Yeah. So estradiol does that.
Oh, grandma.
My mom's 87 and she has.
Yeah. So I would say that no one would recommend her going on hormone replacement, but I would.
Good luck.
Good luck with that, Bill.
I just dose her anyway.
Just take this.
I said a pill some. It's vitamin E.
So yeah.
Vitamin D is for your osteoporosis.
I mean, there's my sister is a doctor, and she is not on the path with me. Yeah, so this is a crazy family dynamic. So my other sister, who's a nurse, is like, I'll take that stuff. She's doing fantastic, okay? She's just absolutely doing fantastic. So
Should have brought my mother to this part. She would.
yeah, so it's hard,
It's the thing everybody.
So that was a battle with my mother. Like, it's a 50-50. Who's she gonna believe?
Doctors and people, they can't all open their minds to the
Is
possibilities.
it, like for your sister, is it because of that old information?
Yes.
It is. So
She's a
it's
psychiatrist,
Okay.
and so she, she's part of that train that cannot be changed. And what can I do? I mean, I can only give you information, tell you what I've learned, give you something to read, but she's seen some bipolar people on very high dose of, sex change dose of testosterone, have a manic event. So for her, testosterone causes mania, right? Which, I mean, I guess we could ask your husband. What does your husband think? You think you're a little bit of a sex maniac right now?
So are those synthetic hormones they use for a situation like that? Sex change?
They used, some of them are methyl testosterone, which is the roid rage, which is why it is a controlled substance. So, so I do prescribe testosterone for sex drive, and I know that I have saved a couple marriages. I know that I have like completely turned it around. So sex is not just orgasm, penetration, you know, let's get to orgasm and I don't feel like it, right? So it's not just that. This is communication, this is touch, this is a need to be needed and to give back. So sex really does play a lot of roles, and I'm not saving the world with sex, but in a way I think I am somewhat, because, you know, if I flip it around, how does he feel when she's like, are you kidding? I got the kids, I got your mother, what? Are you kidding? He feels unloved, right? Unappreciated, like, why doesn't she want me, right? So, I mean, I think we can just do so much better than that. So much better than that.
Well, and I can speak from my own experience. I mean, I had decades of, and I have a wonderful husband, and I just, like, literally, don't come near me. And I didn't know why, and I couldn't do anything about it. And it's kind of a miracle that he stayed and didn't ever cheat or anything. There was no explaining.
How are things now?
And now it's crazy because I have, you know, desire, and it's not, you know, just like sex, but it's like, you know, hug, cuddle, touch, whatever. And now he feels guilty because he's on the other end of it. It's not easy. And one time he said to me, he's like, geez, I waited like 25 years. Can you have a little patience with me? But it's a horrible thing when it's just completely out of your control and you don't even know that it's really something like medically that, you know, you just think you're cold or, you know,
Right.
something's wrong with you. At least
Right.
that's what I felt.
Especially if I was always a bit of a hottie, and then like nothing.
Yeah.
Yeah.
Completely.
So that was, I'm sure, part of talking about taking responsibility for your life, right? So I'm sure that played a role in the dissolution of my marriage. But I mean, I'm sure it played a role. And, you know, none of this stuff happens soon enough for that. But he's a narcissist anyway. Well, everything happens for a reason, and I'm well glad of where it's at. So that's that. So as far as androgens go, it's not just testosterone. There are other androgens that play a role. I specifically use DHEA for patients. So this is adrenal based. So some of our testosterone comes from the adrenals. So some women who've had a hysterectomy still have a very good sex drive because some of the testosterone is coming from the adrenal glands. DHEA is another androgen that comes from the adrenal glands. So it's a supplement. For women, our starting dose is 10 milligrams. For men, starting dose is 50. And then they jump up to 100. I double women from 10 to 20. So, you know, somewhere between 15 and 25 is the average dose for women. Men can go up to 100. So I have one lady whose husband was like kind of on the other end, not able to have an erection when she's finally ready. And so we started him. My recommendation, you don't have to talk to your doctor. It's a supplement you can buy it online. You don't need a doctor. You don't need a doctor. You can it's my recommendation, you could try it. And it's not just getting, you know, like I think this guy actually had like severe migraines if he tried the Viagra or a couple other things. So, so at the 50 milligram dose, he was able to obtain but not maintain an erection. At 100, he's able to have a functional erection they were able to have intercourse. So, great news. One of the biggest things in women as we age is the skin around the vulva and what's happening there. So it is actually feels dry, it is dry. And I tell women that, you know, we're going from when we're younger, the texture of the vaginal mucosa starts out like thick wrapping paper, like the good stuff, like, you know, the stuff the kids sell, the double-sided stuff, $10 a teeny tiny roll, right? The good stuff. And you know, by the time we're completely through menopause, we're talking about dollar store tissue paper. So we have to change skin. This is going to take us a minute. Okay, skin does not change immediately. So I had this one lady who hadn't had sex in 7 years with her husband. Unable, she went through menopause at like 44 and she was 53, so she's just absolutely so dry, so constricted, so unable, severe pain, unable to have intercourse. So she's coming to me for help, and so I, we started her on some hormones, started her on testosterone, DHEA, estradiol, progesterone, and she comes back for the follow-up, and I take a look, let's see how things are going. I come back in the room, and she's on the phone with her husband. Well, she said there's some increased moisture there. Yeah. Okay, oh, the doctor, yeah. So, okay, so let's see what happens. So she missed an appointment, so then it was like 4 months before I saw her, and she comes back, and they have had intercourse, like for the first time in 7 years. And I'm like, you guys are pretty proud of yourselves, aren't you? Like, yeah, we really are. So, not orgasmic. Okay, have you ever been orgasmic? Maybe in my 20s she had been, had some sexual abuse, and so she was not like very open to that or anything. So we had to get that testosterone level up a bit, and then she came back having had an orgasm, and they were like ecstatic. Okay. So as time goes by, I see her, and then she says, "Well, I have to wake him up every morning," and he finally was like, I'm tired. And she's like, oh no. She's like waking him up every morning to service her. And he finally got tired after it was probably about 6 months of every single morning she was waking up. I'm like, okay, well maybe the blood level was a little high. Maybe we can just dial that back just a little bit. Let's find the right balance. So she did just exceptionally well. And she was on a number of psych meds, and we did have to overcome that. And once we did, she's just doing fantastic. I have another elderly lady. Let's go back to tissue paper. We want to at least get up to the regular stuff, regular wrapping paper. Okay, at least let's get there. So she, this is a very interesting lady. So she was, I think, around 84, 85, and came to me with prolapse, and we were putting pessaries in, and it was really, she had some dementia, and her daughter was seeing an endocrinologist that had her on testosterone, estrogen, and progesterone, and she was doing much better with her brain function when she was on it. Her daughter would bring her in, but then things started, not getting great, and this thing was falling out, and so I said, okay, well, we're gonna do a surgery. We'll push everything back up, and so we did the surgery, and they took her off the hormones for the surgery, and she came back at, like about 6 months out, and she was very confused, very unsure of what was going on, but peeing all over the floor, and the vagina was completely inside out, and it was just a complete failure. I was just devastated. I felt so terrible, like what an epic fail. And by this time she was like 87, 88, and I said, well, what's going on with the hormones? What's happening? Well, the doctor won't put her on it anymore. So she, after 86, that was it. He wouldn't put her on it anymore. I said, well, I'll put her on it. I'll put her on it. Let's do it. We'll do testosterone cream, and we'll do the oral estrogen. We'll do oral progesterone, and she was another one. She missed an appointment, so it was maybe 4+ months before I saw her again. And she comes in, she's much clearer. She still wasn't sure that she knew me before, but she was much clearer, much more conversant, much more, doing her word puzzles, and much more with it, able to be redirected. I wasn't going to cure the dementia, but at least it was better. And how's everything going? Everything's fantastic. I'm talking to her daughter. Well, how's it going? She's like, I don't know. Is she putting the cream on? I think so. So, okay. Laid her down. Literally, the vagina was completely all the way up, well supported. I am talking about completely normal, not inside out, just well rugated, thick, strong mucosa, the good stuff, double-sided wrapping paper, just perfect. It was a complete reversal.
Why do you think that didn't happen with the first doctor? Did he have her on different hormones?
He did, and much lower doses, and not following blood levels. So, yeah, so I think
That's cool.
she needed more. So there is research out right now with urologists and trying what's going to work for stress urinary incontinence. What's gonna work for that? My sister had 2 like 7-pounders and then a 10-pounder that she pushed out, and she had stress urinary incontinence always after that. She was wearing pads and diapers and just like, 3 kids, doesn't have time to have surgery. She's not gonna have it. She just doesn't have time. So this is the sister who is willing to take the hormones. So we started the hormones, and she's like, oh yeah, no, I sleep completely through the night. I wake up at 6 a.m. I pee. I take my my thyroid medicine. I go back to bed for another couple hours, and then I get up, and I have no urgency. I never leak. I'm fine. It's fine. It's gone. It's completely gone. All right. Yep. Yeah. That is awesome for patients, I think. All right. Where do you guys want to go from here? Or are we done? How much our
I
time?
know if anyone has questions.
Yeah, I'm ready for whatever anybody wants to talk about. I will talk about your personal, whatever you want to say. Anybody?
Oh my gosh, I don't even know where to start. Actually, I have a question for my daughter, even though she's not here. I have a teenage daughter.
Okay.
She's 15. She started going through her change when she was like 9.5. So she's had her period very regularly for a few years now. One of the things I'm noticing is when she's like getting closer to when she's going to have it, she gets these horrible stomach pains to the point where she won't go to dance, won't go to school. All she wants to do is sleep. But it's not cramping. It's like sick to her stomach. Any?
I'm not sure.
So she's not sexually active, so I haven't brought her to an OBGYN yet.
Mm-hmm. I mean, you could bring her in and they wouldn't necessarily do a pelvic exam, right? They're
Well,
not
she
gonna...
may be coming to you, so.
Yeah, so I don't see a lot of, premenopausal women, but I do see some people's daughters and
But you know what? I'm gonna interrupt you.
Yeah.
Savannah and Kayla had the same problem when they were about the same age.
Did they? Okay. My
Two
cousins.
of my nieces.
My cousins.
what happened with them.
Well,
I don't know what happened with Kayla.
Savannah
Savannah had polycystic ovaries.
Yeah.
So polycystic ovaries usually is not like a painful, and they would usually have like irregular cycles.
Yeah,
so
she was really irregular.
your daughter's
Lila's regular.
Okay.
She is.
So one of my thoughts on that, couple of thoughts. One, it could be something like endometriosis. So
Okay.
suppressing cycles with like a birth control pill could really prevent the growth. So endometriosis is where the lining layer cells dot the inside of the abdominal cavity, and then they make little micro periods every month that eventually pull in a lot of inflammation and scar tissue. So even mild disease can be very painful. Ends up being painful like 3/4 of the cycle sometimes for people. The other thing is people change their diets when they're PMS.
This is true.
Right? So now we're craving, now we're gonna eat some ice cream. And a lot of us, humans should be weaned from dairy. Believe it or not, we should be weaned off the breast by age 5. When the gene turns off, normally it should turn off, right? So, but we live in Western New York, we got the dairy farmers, Milk for Health, none of us are giving up our dairy.
That's us. We grew up on dairy farms. However, we grew up on raw milk,
She was the dairy princess of Genesee County.
I also have
Right.
but I also have no allergies, no asthma,
Rock on, girl.
like
Yeah, so
none of that stuff.
we do eventually, all of us, decrease the amount of lactase enzyme that we make. So lactose is a double sugar, and it's the sugar in milk. It's broken in half by the lactase enzyme, then we're able to absorb both halves.
What about, we'll see, test your knowledge. What about A2 milk? That is naturally, naturally occurring lactose-free milk.
Well, it doesn't have the same gene. It lacks the gene, so it comes from goats and Jersey cows, not black and white dairy cows.
Mm-hmm.
There are some.
There are a few.
They've crossbred with
but
select
it doesn't
gene.
have that, and people are able to digest it better.
Mm-hmm. Mm-hmm. So I've heard of that. Anyway, if you don't split that dairy sugar in half, it sits in the gut wall, causes bloating, alternating constipation and diarrhea, abdominal pain, sometimes severe, gas, foul smelling gas. and I mean, sometimes it's worth it, right?
Look, listen, like a good wrapped brie with some.
Yeah. Okay, so they have those pills called lactate.
I'm thankful I don't have any
issues.
issues.
I tell my husband
love my
to buy stock.
Yep. So, and you might even need more than one pill depending on your dose, right? So, if a dose of dairy is an ounce of cheese or a cup of milk or a half a cup of cottage cheese, then if half a cup of ice cream. Boy, who eats that? I don't know. Right? So that's a dose. So you might need more than one pill.
Oh yeah, no,
Or,
well,
a buffalo size.
The dosage is 3. You have to take 3
Yeah,
pills
9,000 units.
with the first bite of dairy.
Yes. So can that gene be turned back on? Well, my mother was terribly lactose intolerant. She went on like Jenny Craig or something. They wanted her, because of her age, to have 3 dairies a day. So when she started, she needed 5 or 6 of the lactate tablets for a single dose, and by 6 months in, 1 or none. So you can turn it back on. The gut wall. So let's say you overindulge and you have a bout of terrible diarrhea, and you slough off the cells that actually make the lactase enzyme. So now you become 100% lactose intolerant acutely, and then we just keep eating our usual stuff, and now a vicious cycle of abdominal pain and all of the symptoms come into play. It takes about 3 weeks for the gut wall to heal, and then then you'll be making some lactase enzyme. So maybe you're not 100% lactose intolerant, you can tolerate 1 glass of milk, but by the time today's the day that we're having the cheese and the pizza and the blue cheese on the wings, and you have the whole party, then we have dessert, then we have cheesecake for dessert. Now we have a stomach problem.
Well, and it's a whole equation. Like, okay, well I'm gonna eat the blue cheese and the cheese and stuff at this point in the party, because then in 2 hours we're gonna be going home anyway. Because even after I take lactate, I still
So you're not taking enough.
better.
You're not taking
I'm
enough.
not taking enough.
Just buy the Ultra, which is 9,000 units, and
Oh,
go with a couple of those.
Okay.
Walmart's probably the cheapest, and just go with 2 or 3 of them. I mean, do it until it's enough, right? Until it's enough.
right.
Okay. Any
I
other?
have a question.
Of
that
course.
If we were to visit you
Yes.
at your office,
Mhm.
Do we keep our regular OBGYN? How does it look? What is
So
the
I have
display?
many patients who see me, they love their doctor, and they just see me for hormone consultation. So I'm happy to see you for a hormone consultation. You do not have to quit your doctor. On the other hand,
If you
like
don't have a doctor you like, you can do both. That's what
yeah. So, but I'm happy to be the gynecologist too. I can be the gynecologist.
Oh.
Not trying to build my obstetric practice. So when I say so,
Are you a general practitioner doctor or
general
OBGYN?
OBGYN.
Okay.
So, I mean, I do have a few super high risk patients who are pregnant who will probably stay with me forever, but eventually, like I'm 63, so I do over the next couple of years. I have told the program. So I work at Sisters Hospital. I train the resident doctors. I'm with them in the clinic, and then I also do labor and delivery every Wednesday. And on the opposite weeks, I do my private hormone replacement, which I'm building. The practice is building. It's at Sisters. I just this week toured the East Aurora Trinity OBGYN office on Olean Drive. I'm going to be switching my Mondays to East Aurora. Is that helpful? Not helpful? I don't know.
That's super helpful.
Yeah, so that'll be Mondays. Every other Monday will be there, or 2 Mondays a month for now. But I have let everybody know.
Now, would I be able to make an appointment?
You would
there?
still go through Sisters.
So downtown.
Still go through Sisters phone answering, because what I do, they have a PEC or outside service that does the scheduling. They have screwed it up so many times. So now you just call the office, extension 5, pick 5, and then you'll get my office who actually knows what I'm doing and can set you up for a consultation.
Okay.
Consultation visits are an hour, and they're at least an hour.
Okay.
So
And is it private pay for the hormone replacement? Like, so if you're doing
that's a
that.
good question. So
Oh yeah.
I work in the clinic, and I'm probably always going to do something with the clinic, because let me tell you, there is nobody who is treating Medicaid women who are in menopause. Nobody. Not nobody. So I feel like I have to continue to help them, and hopefully those are the patients that I'm mostly seeing with the residents, and trying to leave a legacy, but I do want to focus my practice just on this, and they're being trained in, you know, full OBGYN. So, you know, I have to slowly step away from the residency over the next couple of years and just do the hormones. Most of the hormones are covered commercially, except testosterone is not. They are threatening to take Armour Thyroid off the market. So Armour Thyroid is T1, 2, 3, and 4. It comes from desiccated porcine thyroid, from pork, and all of the impurities are taken out. It's just the T1, 2, 3, and 4. So when they're checking your thyroid, they're looking at the TSH, thyroid stimulating hormone, and free T4 level. So T4 gets converted to T3, and it's T3 that's active at the cell level. This is the one that makes people feel better or worse. Sometimes if you replace T4, just T4, people feel worse because it actually suppresses the conversion to T3. So, but their numbers are good. So they still feel terrible though. So originally there was only, you know, the desiccated portion of the thyroid, and then in the 70s they came up with, hey, listen, we got this new drug, it's called levothyroxine, and we're gonna call it Synthroid, and you only take this, and it's T4 only, and it fixes the TSH, and everybody will be great on it. It was like the greatest marketing campaign of all time. So the Armour Thyroid was dirt cheap. This stuff, very expensive, but you know, went through the stuff, it became eventually generic, and this is what everybody's on, and except for people who don't feel better, right? So at least a third of the people on just T4 don't feel better. So the Armour Thyroid I've been prescribing, which has the T3, and we follow the levels. I would see you, start the medicine. I see you first, order labs, see you back in a couple weeks. Go over the labs, figure out your plan, what we're gonna try, what we're gonna start. Then I usually see you, have you do labs every 6 to 8 weeks, and I see you 2 weeks after the labs, and we see where we're at. This is not a one size fits all. This is not, here's your medicine, see you next year. I'm actually looking at the person and trying to, you know, dose you appropriately. Right now they're threatening to take the Armour off the market, and some insurances are not covering it. They've been threatening to take the Armour off for the last 2 years. Another marketing scam, okay? They haven't done it, but they're, oh, you know what, you're probably not gonna be able to get this anymore. Probably gonna take this off the market. So then what would people do? They'd switch to something, right? Yeah, so I'm still prescribing it. There's NP Thyroid is a brand name for Armour also. If it turns out that it goes off the market, we can give T4 and give a separate prescription for T3. I got a plan. Okay. Is that it? Happy to talk to anybody privately, personally right now. I'm sticking around for a minute if anybody has anything.
Do you have cards that have your
You know
phone
what?
number?
I think that Jared has some.
I'll send it to you.
Yeah, they really have not promoted me at all. They've never made a card for me. They've never advertised for what I'm doing. I just talked to the new manager at East Aurora, so we'll see if they're going to come up with some. You know, so this has all been word of mouth and what I've done. That's it.
Oh God, I know. TikTok.
I
Everybody is.
watch Mary Claire Andrew on TikTok.
Oh, okay.
That's all. Okay.
Thank you so much. Thanks for having us, Jerry. I'm hoping the new manager is going to give me actual business cards.
Thank you.
Give me one of those.
These are so cute.
We made them up.
Did you? I love that.
Put them here. Thank you. Yeah.
All right, that's all I got, people.
Thank you.
You're welcome.
No, this was wonderful.
Was that helpful for you?
Yeah, it was really interesting. I
Okay.
also have